Good afternoon and welcome to TCTAP 2016 wrap-up interview. The topic today is the optimal approach to complex femoral popliteal disease. My name is John Laird. I come from the University of California, Davis. I'm joined by my good friends and colleagues, Dr. Lawrence Garcia from St. Elizabeth's Hospital in Boston, Krishna Rocha-Singh from the Prairie Heart Institute in Springfield, Illinois, and Kazushi Urasawa from Tokaido Memorial Hospital in Japan. So the format today is we're going to take you through a series of slides introducing the topic of complex femoral popliteal disease, and then we're going to open it up to the panel for discussion. So we're going to cover some of the guidelines, recommendations with regards to treatment of FemPop disease, discuss some of the data on drug-eluting stents, particularly the Zilver PTX stent, and then review some of the data on drug-eluting balloons from IN-PACT SFA and Levant 2. And then finally, some discussion about adjunctive therapies for the treatment of the SFA. So what do the guidelines tell us in 2015? Well, the European DCB international positioning is that the use of DCP in femoral popliteal task 2A and B, de novo and restenotic lesions would be highly recommended, whereas the 2013 American College of Cardiology, American Heart Association guidelines did not make any specific recommendations for this treatment of FemPop disease, and this likely reflects the fact that drug-coated balloons became available in Europe a lot earlier than they became available in the US. We have now really good and long-term data on drug-eluting stents in the SFA, and this comes to us from the Zilver PTX randomized trial, where we have data out to 5 years demonstrating a sustained benefit of the Zilver PTX drug-eluting stent over a bare nitinol version of itself, but also against the kind of the standard of care treatment prior to that time of optimal balloon angioplasty followed by a provisional bare metal stent implantation. More recently, we've seen good data in randomized multi-center, multinational trials demonstrating the benefit of drug-coated balloons over standard balloon angioplasty. This is the 12-month data from the IN-PACT SFA randomized trial showing significantly better primary patency with the IN-PACT Admiral drug-coated balloon over standard balloon angioplasty, 89.8% compared to 66.8% at 360 days. In the Levant 2 randomized trial, there was randomization between the Lutonix drug-coated balloon and standard balloon angioplasty in a similar trial design. We saw again benefit of the drug-coated balloon over standard balloon angioplasty with primary patency at 12 months of 73.5% compared to 56.8%. So a little bit more modest benefit, but benefit nonetheless of DCB in this trial. If you compare the two trials head to head, we see similarities and differences. First, I think it's important to remember that the balloons are different and the drug dosing is different on the two platforms. Lutonix drug dose is 2 micrograms per millimeter squared. The drug dose on the IN-PACT Admiral balloon, 3.5 micrograms per millimeter squared. They use different excipient molecules. They were similar in terms of the randomized design, used same angiographic and duplex core laboratories. However, the lesions were longer in the IN-PACT SFA trial compared to the Levant 2 trial. And if we look at primary patency for the IN-PACT Admiral balloon, it did appear to be significantly higher than the primary patency with Lutonix balloon, despite the fact that longer lesions were treated in the IN-PACT SFA trial. Now, there's been some very interesting data from the global registries with both devices. Lutonix global registry showing really quite good freedom from target lesion revascularization in a more real-world patient population. We've also seen really quite good results in the IN-PACT global study. This is some of the data that's been presented within the long lesion imaging cohort, looking at lesions greater than 15 centimeters in length. And we see really excellent freedom from clinically driven target lesion revascularization in that long lesion cohort with quite good safety parameters. CDTLR rate within 360 days, only 11.7% in this trial, with a clinically driven target vessel revascularization rate of 12.2%. Now, one of the other interesting trials of the past years is the definitive AR study, looking at excisional atherectomy in combination with anti-restenotic therapies. And I'm actually going to ask Lawrence Garcia to kind of review some of the data from definitive AR, because he's really closely involved with the design and implementation of these trials. So Lawrence, if you could just take us through some of the data.
Sure. So definitive AR was a randomization between antecedent atherectomy with a drug-coated balloon compared with drug-coated balloon alone. And they looked at about 100 patients, randomizing 50 in each group. And what you're seeing here is the combination of what they call DART versus DCB. In all patients, there was not much of a statistical difference. But if you separated out the smaller groups, which are lesions greater than 10 centimeters, or in the heavily calcified lesions, you saw a benefit, an incremental benefit of the directional atherectomy with drug-coated balloon instead of just a standard drug-coated balloon alone in both of those lesion subsets, the longer lesions as well as severely calcified lesions. And both of those were statistically significant. This is the duplex-driven patency, and it also corresponded to the angiographic patency that was seen in a subgroup of that that were seen primary patency as an angiographic endpoint.
So at least kind of shows some proof of principle here in terms of the combination therapy for the more complex lesion cohorts.
Exactly, and this was all a pilot study, as you're pointing out.
So just to kind of introduce the discussion, for simple femoral popliteal disease, we know that drug-coated balloon is better than plain old balloon angioplasty. We know that drug-eluting stent is better than plain old balloon angioplasty. But we really don't have any data about drug-coated balloons versus drug-eluting stents. We really don't have any data about drug-coated balloons versus a good nitinol stent. So further topics for discussion. And then for complex femoral popliteal disease, we really have a lot of unanswered questions. Is DCB preferred? Should we go with drug-eluting stents? If we treat with DCB and need to stent, should we spot stent or cover the entire length of disease segment with stenting? And then what is the role of adjunctive therapies? Is atherectomy plus DCB, the so-called DART approach, going to be the superior approach in the future, allowing us to get good primary patency and avoiding the stent? I think these are kind of the things that we can talk about, and I'm very interested to hear your opinions. First off, we have a lot of data now, which is great. In some cases, it's a little bit conflicting, but we have data which we didn't have in the past. But do we really have, at this point in time, an evidence-based standard of care for the SFA? What do you think, Krishna?
Well, John, I think what we know is that in the cohorts that were put in the Levant 1 and 2 trials and the SFA trials from Medtronic, with the comparative being angioplasty, to your point, we know that that no longer should be a standard of care for these lesions. These patients don't do well out to 1 year or to 2 years. They come back. And there is some cost effectiveness straight out from the trial that you were co-PI from that suggests there is a cost benefit of that. But once we start moving beyond the inclusion-exclusion criteria of those trials, and I think those trials were more similar than they were dissimilar. I think it's going to be a point of discussion with regards to a potential class effect between these two drugs that were on these the two excipients and platforms. I think we quickly lose data-driven therapy. and we move into the realm of expert opinion. Now, expert opinion is better than no opinion at all, but the fact is how you would approach something may be very different than how you approach something. So I think we're in we're really in a conundrum now, moving outside of the A's and the B's, if you will, with regards to task definitions. And we have to look at the simple fact that we'll never, John, be head-to-head comparisons that are going to be sponsored by industry members. That just doesn't make sense for them. So as investigators, we have to try as principal investigators to have uniform definitions. So at least we can try to start making some comparisons in claudicants, looking at time points of assessment and how we make those assessments. And I think that'll set the platform moving forward so we can make some type of more informed expert opinions with regards to these issues. But right now, your point is simple that it's opinion, and it's just that.
I'm interested in your opinion, Kazushi, about the drug-eluting stents in the SFA. Obviously, we've seen the randomized trials from the U.S. and Europe, and we've seen really quite good data from Japan, the post-market study with the Zilver PTX stent.
Yes.
Has that influenced your practice? Do you use more drug-eluting stents, or is it a selective usage?
Yes, this is difficult to answer, but as you said, in the post-market survey in Japan, included lots of severe disease, including hemodialysis patient, and also lung disease, CTO, and kind of stuff. And obviously, it's completely different from the previous clinical trial, and the result is almost same. The long-term outcome of 2 years, 1 year, 2 years, almost same as the previous randomized trial. So that means something we can improve the result using the Zilver PTX stent. I think the major difference is intravascular ultrasound imaging technology, because most of the Japanese physicians use IVUS for peripheral intervention because it was reimbursed. So we can accurately determine the stent size for each patient, tailor-made stenting. So I think that's the major difference between the Japanese PMS study and the previous randomized trial.
Could the similarly better results be achieved with bare nitinol stents if IVUS was used to help guide deployment of them?
Yes. For example, in a smart control stent, we did the post-marketing survey, including a long task CD regions. Result is enormous. Yeah.
My sense is, although I have not spent a lot of time in Japan, but my sense is that despite the good data from Zilver PTX, there's still a lot of bare metal nitinol stents being deployed.
Yes.
And that the market share for Zilver PTX is still relatively low. Is that correct?
Yes, correct. Yes. In my daily practice, the most of the stent was conventional self-expandable stent, and only limited patient I use the Zilver PTX. The reason is it's the basic character of the stent itself. The base stent is relatively weak radial push. As you know well, in Japanese PAD patient, lots of patient is hemodialysis dependent. In my institution, most of the patient, roughly 60% of my patient is hemodialysis dependent, especially in the case of CLI. So those patients have severely calcified lesion, even in SFA. It's really difficult to dilate, keep the dilatation, status using Zilver PTX. So that's the major reason we use the previous, conventional old style nitinol stent.
And I have the sense in the U.S., despite the fact that we have 5-year data now, good 5-year data with Zilver PTX, that it still hasn't moved the needle a lot, and that there hasn't been really huge penetration of the Zilver PTX stent in the U.S. In that trial, the lesions were very simple, 6-centimeter type lesions, and it's not clear that the results, kind of translate to the more complex disease. Is that your sense, Krishna, too, with the Zilver PTX?
I think there are a couple issues. I think to your point, the initial pivotal trial that drove acceptance or regulatory acceptance of the therapy were in relatively short lesions. And I think it's really what our Japanese colleagues have shown in adjudicated registries that now hopefully will promote the conversation as to what is the best therapy and what's really cost effective. You made a very good point with regards to the issue of more complex disease and calcium. And I do think one of the conversation points has changed where, the instructions for use, the IFU in the United States calls for pre-dilatation. And I think as our experience has moved, we understand that a DCB is a balloon before it's a drug delivery apparatus, and that the pre-dilatation now has morphed into the verbiage of vessel preparation and the issues of calcium and how we obtain optimal stent deployment, whether it be obviously with a drug-eluting platform or just with a DCB, I think is going to really shape our conversations in the years to come. Of course, the problem with that, John, is that when we start moving from pre-dilatation with a PTA balloon to vessel preparation with other devices, we add substantially to the cost of our therapies, and somehow it becomes difficult for us to defend sometimes in the absence of data.
Yes. Adds cost. It also adds time, procedural time, fluoroscopy time, contrast use, and for some busy practitioners, they're not going to want to spend that extra time.
Well, I'd like to ask you, frankly, as the co-PI of a large randomized trial that actually got this therapy on label in the United States. We had a conversation earlier about whether this was a revolutionary technology versus an evolutionary technology. And the point has to be made that if you stay within the confines of the inclusion-exclusion criteria of the trials, these therapies behave very, very well. You would agree, I think all of us would agree. However, we extend just 1 foot past that, and we have data that you spoke of today and was presented also at Charing Cross earlier this week that suggests when we get into these more difficult lesion sets, our use of adjunct technologies and basically provisional stenting goes up substantially. So then we have to ask, we're adding a new therapy, some cost with that, and then we're adding an old therapy to take care of a new therapy. And all of a sudden we find ourselves on a slippery slope.
Yeah.
How do we deal with that, John?
Well, I'm actually okay with that. I'm my own personal experience, with drug-coated balloons since they've been approved in the U.S. has actually been very favorable. We discussed, is this evolutionary, revolutionary? My comment was I think it's somewhere in between. All I know is it's changed my practice a lot. I use a lot of drug-coated balloons now and fewer stents. And anecdotally, have seen, I think, better, clinical outcomes for our patients, even treating fairly complex long segment disease. We end up doing kind of old school long balloon inflations, 3-minute inflations, end up actually with surprisingly good angiographic results with drug-coated balloons. And at least so far, it's equated to, I think, better clinical results. Certainly, stenting is going to be required more often, treating long segment disease and diffuse disease. But we spot stent, and we don't end up, laying down 30 centimeters of stent like we did in the old days, which I think is a good thing. So I'm okay with it. Whether, what's the patency going to look like in those kinds of cases, long segment disease and spot stenting, the real world type lesions, I don't know. I am a little bit concerned about some of the data coming out of Germany, showing drop off in patency between 1 and 2 years. I'll be very interested to see what the global registry data looks like at 2 years compared to 1 year. But at least in my practice, it has changed the way I treat femoral pop disease. I don't know, how about you, Lawrence? What's your kind of sense of things?
Well, I think that what Krishna was getting to is similar to where you kind of ended up with your response. And I think that the kicker for me is that I think that Zilver PTX has been revolutionary, to use another term again, in the fact that it has 5-year data. So this is the best scientific pursuit out there. And it might be that, at least in the short term, we don't have the long stents, which may be one of the ways that it's not really accepted, right? So you end up putting in several stents, which is a cost issue. So if they have one long stent, that might have better acceptance of it. But the idea that the drug-coated balloon in and of itself, as you get longer in the registries, is similar to what the randomized clinical trial. I don't think we're ever going to get that. And the challenge is I think that you always open up a different process when you have longer lesions, and hence the reason for higher stent rates. What would be interesting to find out is how long those stents are. We just have a number right now. We don't know if a 25 centimeter lesion is a 25 centimeter stent. It may be spot stenting, and that may portend again why it's so much better than the DCB alone. But I do think that as we get longer and get into real worlds, we see this decline. And I think this is where the idea of not only success, but how we fail becomes critical here. If you fail in a 30 centimeter lesion that started as an occlusion and it re-occludes, then whatever you did up front probably is not really helpful on that back end. If you end up spending a lot of money up front to get that same result on the back end, it's probably not going to be terribly helpful to you in your bottom line. But if it ends up that it comes back more focal, if the failure road is very limited, then I think that would be a very important thing. And that, unfortunately, is something we never see in any of the data sets. We see a lot of patency, but we don't see the outcomes as to a failure. So it's kind of both ends of that I think are going to be important as we move forward. I still believe that there's an opportunity for this, as we get longer and heavily calcified, for some form of vessel prep, which allows us to do something different, allows us to then get penetration of the drug.
So Lawrence, understanding involvement with DCBs, we have now 2 DCBs that are approved in the United States. Right behind that, I think they're sort of lined up like jets in LaGuardia. I suspect in 5 years we'll probably have 5 or somewhere around that drug-eluting balloons on the market. The hope is obviously that with more competition, price pressures will drive these down. But given that and understanding, in your practice, if you have a barred balloon on the shelf, or if you have a Medtronic balloon on the shelf, and you have a specific lesion, how do you dissociate which one of those devices you're going to pick for your patients?
Well, it's a harder question to answer, but at least on face value, if you look at the baseline outcomes of IN-PACT versus Levant 2, I think on primary patency, particularly at the 2-year data, and I tend to look at the back end of everybody's window. So the front end of the window was 89, but it fell down to 79 when everybody made it through the cohort. But that's important because if you look at the back end of your 24-month window, it was 73%. So they only lost 6% on that year 1 to year 2, as opposed to 89 to 75. So I think that's actually very nice because I think it goes against the German data. It's a very soft landing there. I think Lutonix has a little bit less of a primary patency, both at year 1 and at year 2. And so it depends, but whatever you have or whatever relationship you have, you can do what you want. But for our practice, we use a lot of Medtronic balloons from the shelf. And the other side of it is when you flip over to something like critical limb ischemia. Because IN-PACT Deep, even though we're not doing infrapopliteal work here, the IN-PACT Deep was a very flat negative trial. And so, at least in that respect, until we see the Levant data come through, you really don't have a say in which one. So, if I have somebody with lesions, ulcers or gangrene, and we're working in the SFA, maybe that would be an opportunity to not use a Medtronic balloon, but rather a barred balloon. But again, that's inferred data that I really can't support from a scientific standpoint.
Let's go back just for a second and talk about drug-eluting stents, just from the standpoint of the Boston Scientific Alluvia platform, which has shown really quite good results, in a small study with 96% primary patency at 1 year. Would that change your practice or move the needle for you if that data turned out to be the real deal and they showed in a larger multi-center trial, even with the typical lesions up to 15 or 18 centimeters, showed patencies at a year above 90%?
You would have to consider that to be revolutionary. I think when you start looking at patencies and the associated TLR rates, obviously TLR rates always lag behind, obviously. So if you have 90% primary patency, your TLR rate will be superior to that, right? I do think it would. Obviously, it's always that 4-letter word again, cost, and how much is the incremental value of that second therapy to market. My hope would be because of the competition they would face with the Quicksilver PTX, those would come down. However, as you know, people, if they have and they believe there's added value to the clinical data, that price pressure won't come down a bit. And we probably will have to wait for the third drug-eluting stent to move that needle. But to your point, absolutely.
Yeah.
We'd have to do a slice and dice of the data. Obviously, it's a non-inferiority trial globally. and it's going to be very important prospectively to look at all those subsets.
Can I just say that, do we all agree that the 90% metric is kind of like that holy grail number that we're all seeking? I mean, they really hit it pretty strongly at 96.
Yeah.
I just don't know if it's real or not. And like you said, it's a small trial, but
50 patients. It's hard to say.
Exactly.
A couple of patients here or there, and the numbers are dramatically different. But it sure is exciting. It's kind of, it gives us hope that we might ultimately have something that we could put in and, end up with 12-month patency in excess of 90%. That would be, I think, game-changing.
Yes.
And I think, as much as I like drug-coated balloons and I've been involved in the clinical trials, I mean, you got to pre-dilate. You got to go in with your drug-coated balloon and inflate it for 3 minutes or, a long time. They're relatively short balloons, 120 millimeters, 150 max. So oftentimes we're putting in 2 or 3 and 3-minute inflations and pre-dilating. And then you got to decide with that dissection, am I going to leave it? Or am I going to stent it? So there's all of that. And if I had a drug-eluting stent that I could put in and deploy simply and quickly and with a predictable result and have patency better than 90% a year, I don't know. Kazushi, what do you think?
Yeah, sounds very easy way to go, but it's really limited data, I think. I want to see.
Trying to bring me back down to earth here, aren't you?
Yeah. I want to see long-term data and also more, the number of patients is so small. And the other thing is, I noticed that the failed PTA is depend on the operator itself. When I try the stent trial in Japan, bailout stenting is about using a PTA arm. The bailout stenting rate is about 40%. Right. When I try a drug-coating balloon trial in Japan, bailout stenting is totally less than 7%. So that means, how to do a PTA is quite important to get a nice result. Even in playing on balloon angioplasty, you can get a pretty good result in a short region.
Right.
Right. So I think in a task AB lesion, maybe drug-coating balloon is the best answer to save cost. The problem is a task CD region.
Yeah, that seems to be, from a cost-effectiveness standpoint, consistently the most cost-effective approach is drug-coated balloon.
Yeah.
Drug-eluting stent a little less so, at least in Mark Burkett's analysis and others' analysis. And then, as he talked about today, an atherectomy device. Whenever you throw an atherectomy device into the mix, it just is not a cost-effective strategy. No matter how good your patency is, even if it's 100%, it becomes not a cost-effective strategy. Maybe that'll change, down the line when the devices become cheaper. We'll have to see. We'll have to see.
I think it will always depend on anatomy, right? Because
Right.
I think we still have to fight. You're a big champion of calcium, and I think that until we know how we deal with these very long 25, 30 centimeters of heavily calcified arteries, how we go about either vessel prepping it, does it require atherectomy to get that outcome, I think that niche is still there in our current environment. It's just I don't think we have our opportunities yet to say one and done is our therapy, which is unfortunate. I'd love to see it different, but it isn't.
We didn't talk at all about stent grafts, covered stents, Viabon, and the SFA. Maybe just ask very briefly, go down the line. Do you use them, Lawrence?
I've used them sparingly. We have an internal data set which is a little iffy when it comes to their use, but I still like it for recalcitrant restenosis in many cases. Yes.
Krishna?
I think my practice has changed, basically looking at the ISR data from DCB, although obviously that's sort of limited in European. Not that that's a bad thing, but obviously you'd like to see it replicated in the United States. My previous use was for ISR of stent grafts. Now I think I've become less of an implant. Obviously a DCB in that situation is far less than stent grafts. So I have moved my practice in that regard.
Okay. Kazushi, I know Viabon was just recently approved in Japan. Have you used it yet?
Yes, not yet used, but the Viabon will be released within this year. So
Okay.
Not we're gonna use right now, but I'm involved in a clinical trial in Japan of Viabon, and I experienced the restenosis reocclusion of Viabon patients, and I implanted 25 centimeter Viabon, wrong SFA-CTO lesions, and occluded, everything is thrombus. It's terrible.
Yeah.
Yeah.
Well, this has been a great discussion. I'd like to thank my panelists
Yeah.
for this excellent review of the treatment of complex femoral popliteal disease, and I hope you enjoy the rest of TCTAP.